Welcome to the deep dive. Today, we're cutting straight to the core of predicting outcomes for patients with uncomplicated acute type B aortic dissection. We'll call it UATBAD, yeah.
Yeah, UATB for short. It's much easier.
Definitely. Think of this as your kind of express route to the key insights from a really important study.
Exactly. We're unpacking a 2016 paper from the Journal of Vascular Surgery.
Mhm.
It's all about predictors of intervention and mortality in these UATBAD patients.
Right.
And what's really valuable here is, trying to spot which patients, even though they seem uncomplicated initially, might actually be heading for trouble and need more than just standard medical therapy.
Okay, so let's unpack that standard approach first. Historically, if someone has UATBAD, that's the tear below the neck arteries, no immediate catastrophic complication.
Right. Yeah.
The usual plan was medication, wasn't it? Blood pressure control, heart rate management.
That's been the standard playbook, yes.
Yeah.
Support the body, let it heal. But what research like this is showing is that it's not quite so simple. Within that uncomplicated group, some patients' dissections are just, well, more likely to worsen over time.
So the goal is to find those people earlier, before things go wrong.
Precisely. To get better at identifying these higher-risk individuals, maybe they benefit from an earlier intervention, like TAVR.
TAVR, that's the endovascular repair using a stent graft.
Exactly. Delivered via catheter, less invasive than open surgery, potentially preventing bigger problems down the line if we pick the right patients.
Okay, so how did this specific study try to pinpoint these warning signs? What was their method?
Well, it was a retrospective review. They looked back at, I think, 294 patients admitted with UATBAD between 2000 and 2014.
Right.
But for a really detailed analysis, they focused on 156 patients where they had good quality admission. CTA scans, the computed tomography angiography.
And these weren't just any scans or any readings of the scans, I gather.
No, definitely not. They had a specialized cardiovascular radiologist involved
Okay.
who used multi-planar reconstruction software. So creating detailed 3D views, essentially.
To get really precise measurements.
Exactly. They use a specific technique, double orthogonal oblique measurements, to get the most accurate maximum aortic diameter and also the diameter of the false lumen.
The false lumen. That's the kind of new channel the blood flows through after the tear.
That's the one. So super accurate imaging measurements right at the start.
Got it. So detailed imaging on 156 patients. Then what? They just track them over time.
Pretty much. They followed them for, on average, about 3.7 years, looking at two main things. Did they eventually need an intervention? And, well, did they survive?
And then connected that back to the initial scan findings.
Correct. Using statistical analysis to see if those initial measurements could predict what happened later.
Okay, this is where it gets really interesting. What did they find? What were the big red flags?
The most striking finding, arguably, was about mortality risk. The maximum aortic diameter on that admission scan was critical.
Yeah, so?
They found a cutoff point. If the aorta was wider than 44 millimeters, that was the most sensitive predictor for mortality.
Greater than 44 millimeters, and you set a cutoff point, like a threshold.
Exactly, a threshold effect. It wasn't just a gradual increase in risk. It seemed like once you crossed that 44 millimeter mark, the danger of dying significantly increased.
Wow. Did they quantify that risk?
They did. After adjusting for other known risk factors, things like diabetes, age, stroke history, connective tissue disorders, even syncope or passing out, having an aortic diameter over 44 millimeters carried a hazard ratio of 8.6.
8.6, so nearly 9 times the risk of death compared to those below that threshold.
Almost 9 times higher risk, yeah. It really suggests that once the aorta gets that stretched and weakened, its structural integrity is seriously compromised. Much more prone to rupture or other events.
That's a huge number. It makes you really pay attention to that measurement. Now, what about the false lumen, the other channel? You'd think its size would matter for survival, too.
You would think so, wouldn't you? But
Yeah.
interestingly, in this study, the false lumen diameter alone did not predict mortality.
Really? That's surprising.
It is a very important distinction. The overall size of the aorta seemed to be the bigger danger signal for survival itself.
Okay, so 44 millimeter diameter is bad news for survival. What about predicting the need for an intervention later on? Did the false lumen play a role there?
Yes, here the false lumen size did come into play, along with the overall diameter again.
How did that work?
Well, for intervention-free survival, basically, staying out of the operating room, they found a couple of things. First, Looking at the aortic diameter again, within the range of 35 to 44 millimeters, the likelihood of needing an intervention actually decreased as the diameter got smaller.
So below 44 millimeters smaller was generally better for avoiding procedures. Makes sense.
Right, but if the false lumen diameter was greater than 22 millimeters, that was linked to decreased intervention-free survival.
Okay. So a wide false lumen, 22 millimeter, meant you were more likely to need a procedure down the road, even if it didn't predict immediate mortality risk.
That seems to be the implication, yes. And maybe unsurprisingly, that overall maximum aortic diameter being greater than 44 millimeter was also linked to decreased intervention-free survival.
So that 44 millimeter aorta is a double whammy, predicts higher mortality and a higher chance of needing intervention. And the 22 millimeter false lumen predicts needing intervention.
You've got it. That seems to be the pattern they observed.
Can you give us some concrete numbers on those intervention rates? How different were they?
Sure. For patients with that initial aortic diameter over 44 millimeter, the intervention rates were, well, pretty high. About 19% needed one within a year.
Okay.
Nearly 30% within 5 years, and over 50% half the patients within 10 years.
Wow, 50% at 10 years. And compared to those with smaller aortas, 44 millimeter.
Much lower rates.
Right.
Less than 5% intervention at 1 year, about 13% at 5 years, and interestingly, still around 13% at 10 years.
So a huge difference. What was the overall odds ratio?
The overall intervention rate was significantly higher in the 44 millimeter group. The odds ratio was about 4.12. More than 4 times higher chance of needing an intervention if your aorta was larger than 44 millimeters at admission.
Really underlines the importance of that measurement. Now, you mentioned age earlier as one of the risk factors they adjusted for. Did age itself stand out as a predictor?
It did, yes. That was another key finding. Patients older than 60, when they were admitted, had lower survival rates compared to those 60 or younger.
And that held up even after accounting for the other factors.
Yes. Age over 60 remained a significant predictor of mortality after adjustment. The risk increased slightly with each additional year over 60.
Okay, so the big 3 predictors seem to be aortic diameter, 44 millimeter, false lumen, 22 millimeters for intervention, and age 60. How common were these factors in the study group? Did many patients have them?
That's a really important point. A large majority, actually. 69%, almost 7 out of 10 patients in their detailed analysis, had at least one of those 3 criteria.
69%. That suggests many uncomplicated cases aren't so straightforward risk-wise.
Exactly. It suggests a substantial portion of these patients might harbor risks that weren't always fully appreciated under the traditional management approach.
Did the authors talk about why they did the study? What was their motivation?
They did. Their main goal was really to refine risk stratification, to get better at identifying these higher-risk UATBAD patients early on.
So intervention could be considered sooner.
Potentially, yes.
Yeah.
Before major complications like rupture happen. They also stressed the importance of their methodology, using the modern 3D software and standardized measurements.
Why was that so important to them?
Well, they felt some previous studies maybe hadn't been specific enough about how images were measured, which could limit how reliable or repeatable the findings were in, everyday clinical practice.
So they aimed for more consistency, more clinical relevance.
Precisely. To find measurements that are dependable and readily identifiable. And based on their results, they concluded that the findings do support considering earlier TVAR for patients presenting with these specific high-risk features.
Of course, no study is perfect. Did they mention any limitations?
Yes, they were upfront about that. It being retrospective is one. Looking backwards always has potential biases.
Right.
And also, the fact that they couldn't get admission scans for everyone in the initial larger group because of, hospital archiving systems, that limited their final analysis group size.
Understandable limitations. So even with those caveats, what's the big picture here? Why is this study significant for clinicians dealing with aortic dissection?
I think the real value is that it provides concrete, data-driven criteria to help identify which UATBAD patients are actually at higher risk than their initial uncomplicated label might suggest.
Helping to decide who might need more than just medication and watching.
Exactly. It helps refine that decision-making process. The authors themselves called for more research to hone these criteria even further, to really pinpoint who benefits most from early intervention.
And for you, the listener, maybe not in the medical field, what's the relevance? Why should you care about these specific measurements?
Well, I think it highlights how complex even seemingly uncomplicated conditions can be. It shows the power of detailed medical imaging and careful risk assessment. And, it illustrates how medicine is constantly evolving, trying to tailor treatments better to individual patient risks.
Okay, let's try and boil this down. What are the absolute must-remember points from this deep dive?
The key takeaways, I'd say, are: 1. An aortic diameter over 44 millimeters on admission is a major red flag for mortality risk in UATBAD patients.
Yeah.
2. Being over 60 years old is also linked to worse survival.
Right.
And 3. For predicting the need for future intervention, both that 44 millimeter aortic diameter and a false lumen diameter greater than 22 millimeters are important indicators. They suggest a higher chance you'll need a procedure down the line.
So wrapping up this deep dive, here's something for you to think about. Given these findings, which really challenge that one-size-fits-all medical management approach for UATBAD, how might treatment strategies evolve? As we get better at spotting these high-risk folks early, what are the wider implications of relying on these very specific imaging measurements, 44 millimeter here, 22 millimeters there, to guide potentially life-altering treatment decisions? It's a space that's definitely changing, and studies like this are paving the way. Thanks for joining us on the deep dive.